Thank you. Thank you so much for the invitation and for the possibility for this talk and for the introduction. And it should be probably after all this excellent scientific presentation, probably will be really easy to digest today. It's not a lot of answers here and not really scientific presentation from me, but it's still important for awareness, and it's still important to talk about hepatitis C elimination goals and gaps that we still have. So the problem is we still have about 50 million people in the whole world living with hepatitis C. And it you see on the map, it's not like in HIV. So we have here no disproportion between continents and countries. So in each continent and each country have a huge number of patients with hepatitis C, and many of them are still without appropriate diagnosis and without treatment. The interesting that only from all these countries, only 38 countries do the 80% of all viral hepatitis and death by here in this picture you see on by WHO regions, and for especially for the European region, you see here that all these countries that have the huge epidemic of hepatitis C, that's the former Soviet Union countries. It's Russian Federation, Ukraine, Central Asian countries, Kyrgyzstan, Uzbekistan, it's Republic of Moldova and Georgia. This is we still have invest in South European countries a lot of hepatitis C, but it's still a country with a huge prevalence, and we see now I show some data later. Why we need hepatitis C elimination? First of all, we treat people. As a physician, we improve health, we improve outcomes, we improve survival. It's clear. But we also will reduce hepatitis C transmission. So it's hepatitis C is also known treatment as prevention. And this is actually the aim of this, all this measurement, all the things that's to eradicate hepatitis C. We talk already about WHO targets to reduce the new cases and deaths from chronic hepatitis. And it just to remember what are WHO targets. There are 90% reduction in new chronic infection, the 65% reduction in new hepatitis-related deaths, the 90% people with hepatitis C should be diagnosed, and 80% of these people should be treated, which are goals of the WHO. The question, what we are now, what our achievement, what progress we achieved till now. We have treatment which are really, really effective and well tolerated. So we have the DRAs with 95, it's still even more % of cure. We have 15 countries still on the track on elimination till 2030. They have national strategies in more than 120 countries. We still have, it's not a lot, but we still have 20% of patients are diagnosed already and 13% are treated. And we see now increased access to DRA to hepatitis C drugs in low and middle income countries because of generics. But we still have a lot of gaps. Which gaps we have? First of all, 60 to 80% of all people with HCV are still living without diagnosis. The treatment, because of treatment, we have a gaps that only about 30% of all diagnosed people are been treated till now. And we have the big problem with the risk population, which are still people who inject drugs, that people in a prison, the people living in a rural or remote regions, not in the big cities. And we have the huge problem now with hepatitis C prevalence in migrants, because it's a very vulnerable group of people. It is difficult to treat. We have a lot of stigma, and still we have a lack of awareness even in medical health person. What about the European region? If you look for the WHO report, they see that European region it's shown not the best results because of the coverage of diagnostic and treatment. They still see about 29% of diagnostic coverage and only 9% of treatment coverage in whole European region. It's 9% of all people living with hepatitis C. And why it happens, what is the reason of this gap? So first, we have low in the uptake of the tests. This because of stigma, because of a lack of awareness, because of the limited access to tests. We have fragmented care and treatment pathway and cascades because we have on the one side the centers who make diagnosis, and on the other side the doctors who treat it, and a long way between diagnosis and treatment, so which is make this also much more difficult. We have a lack of integration in the primary care, healthcare, and the harm reduction services, and we have not enough tools for sufficient surveillance data and surveillance systems. This is a typical way of the patient with hepatitis C. So the first visit we have anti-HCV antibody test. So we do blood test, we send to laboratory, we wait for results, we see results are positive. We still have no idea, is it some past infection, it's an relevant infection. We're seeing a second test, we look for HCV RNA, and we see the patient is positive, and we have diagnosed HCV patient and could start treatment. It's too long. As in my own experience, it's really too long, especially for the people who inject drug, for example. You see people, you make a first test, you never see the people again. So this is a problem. Are there some strategies to close these gaps? Yes, there are. So we have, we try to discuss, don't afraid and don't like to discuss all the strategies, but some of them are probably some examples, some successful examples of strategies, how we could try to expand testing, to simplify pathways for treatment, to integrate hepatitis C services in harm reduction system, how to improve data system, for example. The first, I'll try to start with expanding test and point of care diagnostic. Why it's important? Because we have different healthcare facilities. It's not only hospital, not only doctor office, but it could be also harm reduction center, drug and alcoholic clinic, syringes services, sexual health clinic, pharmacies. So it is this all location where we could use test, point of care test. And we could on this way, we could reach really this hard to reach population using different types of intervention. The advantage of point of care test compared to standard of care test is you do it everything at one visit. It's already implemented successfully in different settings, like in prison, in mobile clinics, in needle syringes programs, in a program for people who use drug, for example, in sexual clinics. And comparing to standard of care, the point of care testing have a lot of advantages because it reduces the time between diagnostic and treatment initiation, the increased uptake of the treatments, and reduce the loss of follow-up of patients. This is one of the success stories from US, from Johns Hopkins HIV cohort. They started treatment HIV testing in the same place, and for HIV positive people for hepatitis C, and they see already reduction in new HCV cases in their cohort because of treatment as prevention, because of starting this program. That another example that we, I just would like to show it, we do now in Germany. It's started since 2021. It's a program for everybody, not for the risk category of people, but for everybody. About 35 make in Germany like check for the health check, and it's integrated to this health check for everybody once test for hepatitis C and hepatitis B. It should be enough for the people without risk to make it only once in a life, but we still see a lot of patients without any risk that they get new diagnosis of hepatitis C and hepatitis B and could be successfully treated without any clinical symptoms, without any clear risk factors. So it's everybody could get it. It's paid by insurance, and it could be done by any general practice. And it's important, it's reflex testing. So it means it's only one blood test sent to laboratory in case of HCV antibody positive. It will be reflex testing for PCR. That's all. So that's not needed for second blood test or second visit. How could we simplify the care pathway between test and treatment? So we have already very easy treatment strategies. We have combination treatment. Treatment is really easy in any practice, in any general practitioner practice. It's possible. It's high effective for HIV positive and HIV negative people. And we have some issues with the pregnant women because of label issues of medication, but it's still could discuss anyway about advantages, disadvantages. Probably the most important, all young women, especially in risk to treat before pregnancy, because it's in label, it make life easier. And we try to treat immediately as soon as possible. Which people are qualifying for the simplified treatment? First of all, so it's treatment for everybody. You don't need for such type of treatment an infectologist or gastroenterologist or special clinic, university hospital or center. That are people with adult people with chronic hepatitis C, independent with genotype, without cirrhosis and without previous treatment. This is easiest case of the treatment could be done even by non-medical staff. Who is not eligible for this treatment, the people with liver cirrhosis, liver cancer, or the people with known unsuccessful treatment before, or some difficult cases, or the patients prior liver transplantation, for example. We have easy treatment, either glycaprevir pibrentasvir for 8 weeks or sofosbuvir velpatasvir for 12 weeks, which is not really different in efficacy. It's some small details concerning with food, without food, or some drug-drug interaction. It's a difference between medication, actually. That's another good example or some success story from Egyptian. So that's show, you see it's very interesting. It's even in a minute show how long it takes to get one diagnosis of hepatitis B or hepatitis C. So you see it's 15 minutes for HCV antibody tests and a little bit more than 1/2 hour for the HCV RNA, and you have diagnosis, and probably don't even need all this special additional testing like FibroScan, because for the people without cirrhosis, it's not necessary to do all these tests to start treatment. How could we integrate, or how important to integrate hepatitis C treatment in a harm reduction program? So you see on this example that people who stay in opioid substitution treatment with buprenorphine, for example, show the better results concerning HCV treatment, initiation treatment, and concerning results in compared to people who are not in a substitution treatment. It's pretty easy to combine all the things we try to do in our practice. We combined opioid substitution treatment, hepatitis C and HIV treatment, and once, not to send to different clinic and try to do it at the same place, because it's easy. It's easy for patients, it's easy for us, and it shows better results. Because many doctors are afraid about hepatitis C reinfection, especially in the people using drug, it's not so high as we expected. So we see some reinfection as well, but it's not so high, especially in the patient who are on a stable opioid substitution treatment. It's between 3 and 5 per 100 per year. It's depend on the city, on the country, or the settings, but it's still not so high. We even we have unfortunately I don't have results results here right now, but we have even a study in Germany that shows that reinfection in MSM population in Germany was higher than in PIVETs. And it's most important, the recent and active drug use, it's not more contraindication for hepatitis C treatment. And it's not necessary to do pre-treatment screening for drugs because it creates a special additional barriers for treatment. It's absolutely not necessary. We have a lot of results that people using drug and not using drug on substitution treatment, on or without substitution, they would have the same results, the same efficacy in the treatment. It's not necessary to ask patient about to stop using drug, whatever. It's important to discuss with the patient about reinfection, about prophylactic after the treatment, but it's not necessary to do it before. It is probably a last example that I would like to show. It's another example from Germany about real-time monitoring. It's really helpful for the physician to see what happens on the country level, how many people we already diagnosed and how already treated. So it's a real-time tool that it gets from different sources data and I put in one tool. It's everybody, it's free. Everybody could look at how many patients actually be treated in Germany, how many already diagnosed, and how long it takes till we reach WHO goals. At the end, just a few words. We have still some specific settings, some barriers in especially in the people in the prison, in migrants, in people in rural and very remote population for the treatment. And probably some innovation and technology could help us in the future, like as I showed, this digital health tool, self-testing, or telemedicine probably will be helpful. Thank you very much for your attention.